going to talk about the robotic argument. And then after that, we'll have the laparoscopy, and then whoever wins will get the prize. Yeah, 1.2.
So I know it's been a long afternoon, so I think Dr. Pillai has already done the job for me. Maybe I should give the podium to Dr. Vithiananthan to come and listen to his point about benefits of robotic surgery. So as a start, I have no conflicts of interest other than the fact that I am passionate about this topic. And let's see, so I'm here to talk about the process for robotic surgery, but I have to say, hand over to Siva for traveling all the way to Sri Lanka and to train our colleagues on doing laparoscopic surgery. So there is a role for laparoscopic surgery, but not in the US, I think. So we'll see. So this is Siva with his fellow there, training them, and because what he did, I was able to go back in January 2023 and do a living donor transplant in Sri Lanka. So I thank him for that. But that's all. It stops there now. Now the real game starts. It's asking to compare laparoscopic surgery to robotic surgery. It's asking to compare tennis to table tennis. It's two different games. How can you even compare? Let alone asking someone to eat a steak with the chopsticks. It's using the elbows versus using the hands. It's day and night, and I'm not sure why we're having this discussion today. I think it's time to evolve from the Stone Ages to come to 21st century on robotic surgery. So I know it changes hard saver, but let's try. In 1983, in early, it's German surgeon Henrik Moore that when he came to American College of Surgeons to present his cholecystectomy data, the college we respectfully said is unethical. We shouldn't be doing minimally invasive surgery. We should be doing open surgery, and that's just 40 years ago, 45 years ago. And since then, we know how we have evolved with minimally invasive surgery. And Siva told me he needs 15 minutes, so I have to rush through. So I have to get my talk done in 10 minutes, so he will have enough time to present his stuff. And when it comes to robotic surgery, it has evolved, but it has revolutionized laparoscopic to robotic surgery. And so far, we have had 4 different generations of robotic surgery, and the model we use now is XI, and there's another one after that I'll talk about. So, there are multiple benefits of it. As I said, it's operating with your elbow or you operate with your wrist. Then why do you do open surgery? We don't operate with our elbows. You operate with our wrist in the OR and open cases, and that's what we are doing. So how I evolved with robotic surgery, it's a different platform. I started with cholecystectomy, the simplest surgery, got comfortable. You have to become one with the machine. I think that's the key. And once I got comfortable with all the aspects of the robotic surgery, then I progressed with hernia repair and complex hernia repairs. And then I jumped to the area that I'm most comfortable with, liver and pancreas, with distal pancreatic, and then Whipple procedures. So I'll just give a couple of quick examples here. And here, essentially, the benefit is you can see what I'm showing here is maybe it's a short video. It's what I'm separating over here. It show the, oh, it doesn't show up. At the bottom right is I'm in the uncinate process doing a Whipple. This patient has a replaced right hepatic artery that I'm able to get underneath with a hook, and it's hard to make that move when you're doing straight stick surgery. So I think that's the benefit of doing it. And when it comes to reconstruction, and let's see where this place. And this pancreatic duct, when you try to do open surgery with loops, I've been doing Whipples for about a couple of decades. I've never seen pancreatic duct so well. It's like I put my eyeball right next to the pancreatic duct, and it's suturing backhand, and it's in fact now I think I have less leak rate with robotic surgery than I have my open surgeries, and it's like day and night, and I don't have this. If I have to do laparoscopic Whipple, I'll probably be there all day trying to get the specimen out. So with this, our operating time is almost same as open surgeries. And when these patients come back to the clinic, that's how they look. It's essentially minimally invasive. They had an extended flat folio. That's what it looks like. And can you imagine this is one of my patients? He's a wrestler. He's BMI 50. He's all muscle. If I have to do open whipple on him, the amount of mobility that would have caused for his abdominal wall and so on. And these are the newest version of the robot system now called BB5, which has tactile feedback. It's a total game changer. It's like even I can let my residents do complex surgeries because it gives them that tactile feedback, and the visualization is even better. Ergonomics are better. And what's essentially I'm showing you the next couple of slides I got from Intuitive, which shows that number of cases that are going up and the rate at which the number of cases going up are higher for general surgery than gyne or urology we put together. The dark blue is the neurosurgical caseloads. And these are the cases that are being done globally. It's 2.2 million cases just last year, for nearly 15 million cases during the year. These are the number of systems they have, about 8,000 and 5,000 in the US, most of it. And this is, again, the benefits is going to be with AI and all, it's how you can use remotely. And now the benefit is we know this access to surgical care is globally. If you have an access to a robot, you can maybe potentially do this remote surgeries as well. This is my picture from this Monday. A few days ago, I did my first robotic donor nephrectomy. Took me about 2 hours. And the only question I asked myself at the end of the 2 hours is, how come it took me 2 decades to transition to this? I had no back pain, no neck pain, no leg pain. I mean, it was a game changer for me. And as you can imagine, this is me trying to operate at all kind of crazy angles to get to where I need to get now. I can operate in the comfort of a robotic console. I do believe robotic surgery is here to stay, and it is true, like Dr. Pillai earlier on said, for advanced complex cases, if you're doing minimally invasive, I think robotic is the platform to use. So there you go. And I just want to thank all my mentors from here, and a quite quick reminder, the World Congress is going to be in Singapore, December 4th to 6th. All right, Sivamainthan, good luck to you.
You're really a great opportunity.
I'm giving a 5 minutes to undock. Thank you, Tab. Thank you. You're a good undocker. All right, let's see. Is my talk here? Go ahead. Let me, while this is going on, let me talk about a couple of things that Jeff said. He did take a little bit of time to undock there. I felt badly for him because I saw him ask Siri for direction to come here. So dependent on technology, he can't even get downstairs to I also eased up on my drinking. Now my tremors are gone. Maybe you should try that next time when you do the pancreatic duct anastomosis. You don't need a robot for that kind of thing. So, all right, you got it. Good. So the question here is it a revolution or evolution? Right? That would be robotic and laparoscopic surgery, and I don't have any conflicts. So, you know, before I did this, I wanted to check my opponent, and I Googled him. He had 3.8 stars. I think that's pretty good. He's a president-elect, well-bodied, and that's very a decent job to go into. He's a full professor. He's a program director, and I thought he would, produce some good data. I did not see data. Did you see data? No. He's highly rated by the patients, and but I think he does like the money. I think he's a transplant surgeon. It's an expensive surgery. I think he likes to spend money, and I think no wonder he's really talking about robotic surgery. I think he comes from the powerful state of South Dakota. We know the power that South Dakota has, and he does have an MBA, so he understands a lot of the issue of value, quality divided by cost, right? You've heard that. Hopefully we can touch upon that. So with that said, I know what a revolution is coming from Boston. It is a change that you change the way you do things. We just heard an excellent talk about Al-Zabari, how he did things open for centuries. Guess what? When did that change? When laparoscopy was introduced. Okay, we started with laparoscopy, and it was a revolution. You would see it. You know it when you see it. You showed me some laparoscopic trocars and called it a robot. Okay, so as ICS, we need to really know what we do. We are ICS. We improve lives of patients worldwide through advancement of surgical education, training, and collaboration. Okay, so in that sense, we are really dedicated to providing care for the poor around the world. The poorest 1/3 of our nation spend less than $100 a year on health. Only 3% of the patients who need surgery actually get them. 2 billion people don't get surgery. Do you think I can talk to them about robotic surgery? Do you think I can really scale that, Tam? I don't think in MBA class that they would support that. So we need to have a cost-effective technology that can be immediately scaled, right? So that's the important thing. You look at the Essential Surgery Bible from 2015 that the Disease Control Priorities group and the Lancet group published, and they came up with some surgeries that are important because they are the most cost-effective surgeries that one can do, right? It would avert about 1.5 million deaths a year, or 6.6 to 7% of all avertable deaths in those countries. What are those surgeries? They didn't talk about pancreatic cancer. They talked about laparoscopy, hernia repair, appendectomy, and cholecystectomy. Basic surgery. Right? We don't talk about transplant there. All right? So what surgical revolution happened was during laparoscopic cholecystectomy in 1985. Within 5 years, it spread like wildfire. That is a revolution, ladies and gentlemen. Okay? Cholecystectomies, and what they did was they decreased fewer infections by 70%. That's the revolution. Okay? They had 5 times less complications, shorter hospital stays, and you know all that. I don't have to tell you. Now, it did, reach globally within 10 years, right? Low cost setup. We are not giving them $2.5 million when they cannot afford $100 to get surgery done. All right? And WHO has claimed there's about 70% reach in laparoscopic surgery. Robotic surgery has been done since 2000 as less than 5% penetration rate. I wonder why. It costs $1.5 million or $2.5 million to get a robot, just to park it. Okay? Then you need about 170K to maintain it. You're not even adding the tariffs. Okay? The disposable tools, another $3,000 a case. And it was built on laparoscopic fundamentals. It was not a revolution. It was just an advancement on revolution. So let's not stop there. Let's talk about cost per case. You know, I'm sure your chairman is asking about that question. If you did a hysterectomy, it's almost double. Prostatectomy, the golden operation of robot is almost 1.5 times more expensive. There's no consistent clinical benefit from robotic to laparoscopy. There's none whatsoever. So, but if you look at the revolution in laparoscopic surgery, it changed the vision and the coordination skills of surgery. It actually started subspecialties in surgery, and today we heard our president wanting to have a geriatric subsection and an AI-driven subsection. It all came from laparoscopy. It really established a training model globally that is different, the simulation-based training model. This did not happen in open surgery. That is a revolution. So, evidence-based guidelines of surgery, I'm sure, as an academician, we should have talked about it. But you know what? I didn't see that in his talk. I saw some slides from data, real good data that Intuitive provided. And sure enough, analysis surgery said 52% of the studies were supported by industry, and 91% of the authors were paid by Intuitive to present their data. Okay? So the median industry payment is $33.64. And if I had that money, I'd go to another meeting. Okay? So let me talk about one case that I think illustrates data. If you look at the JAMA paper in 2023 out of Michigan, good old state of Michigan, looking at their data, about 1 million patients. They looked at bile duct injury on robotic surgery versus laparoscopic surgery. And this is 20 years later, not in the first year of your career. 20 years later, you have about 3 times more injury rate with robotic surgery, about higher biliary intervention, and the complication rate is similar, but serious complication rates are high. Knowing that information, would you still call it revolutionary? Yes, it is revolutionary because there's so much violence in robotic surgery. That's the only revolution that I see. So, now, if you look at FDA reports, there are a lot of deaths. If ladies and gentlemen, there are a lot of deaths in the first 5 years that laparoscopic surgery happened, do you think that would have been shut down? Yes, of course. Right? But FDA reports in the first 13 years have reported 74 to 93 deaths from robotic surgery related injuries. So, with that said, the only thing that is revolutionary is the stock price. Okay? I wish I bought some stocks, but nothing else is revolutionary in robotic surgery. So, with that, I wanted to talk about a couple of cost items. Now, if I had $1.5 million to quote the Bare Naked Ladies for their song, if I had $1 million, what would I do? I would buy 5,000 screening colonoscopies, give 80,000 HPV vaccines, do 100 cholecystectomies, and 200 hernia repairs. Or should I just do one robot and I can't even start it? So, these are the mean operative charges for robotic and laparoscopic surgery in euros. But you can see how expensive the robotic surgery is. So, is it a deal or no deal? Now, Is this what we're trying to do? Wrap up robots in a hut and throw away all these unusable parts every day, paying $500 off? I don't think that's what the revolution is all about. It is not what this equation is. Value. Value, as you know, is based on quality and the ratio between quality and cost. The quality, the best case scenario, I'll give you an even. I just said how bad quality is, but I'll give you even. The cost, I just told, is worse. So with that, you know the math, the value composition stamp. I know your MBA will take it now. Why don't you wake up,
Ooh, that's a tough one to follow. All right, but I think you needed the 15 minutes though. So, I think Professor Vithiananthan probably did not get the memo from Chad. His talk was about the surgeries in the US. That's okay. We'll let that go. We'll let that go. But I think it's Steve Jobs who said, your customer doesn't know what he needs or she needs. You have to tell them. Because our people didn't think about smartphones. We have to show them this is something new. This is what we as leaders doing, telling our patients what they need. Can you guys imagine the first computer that we had in the world, how clumsy and big, will occupy the whole room? Now the smartphones that we carry is more powerful than Apple 13. Did you know that? That's crazy. And yeah, it is clumsy, the current robot system. I agree, it is expensive. The price is now going to go down, we know that, with computation, new computation coming in. But I think maybe the people in Detroit and Michigan and Boston are still having the learning curve with the robot. That's possible too. We have a high rate of complications and so on. And then we know in laparoscopic surgery, hey, he started it. In laparoscopic surgery, it's very, he said it's a groundbreaking, it's a huge change. But whenever the lap folding when we started doing, the bowel duct injury was 1 to 2% compared to 1 in 1,000, 0.1. And that's what the robotic fully is, so there are some errors going on, but it will get better. But the reality is I don't want to keep giving the data. Now it's inguinal hernia is done more robotically than open in most of the academic centers. That's the reality. And you ask a resident about how to do an inguinal hernia, they look at you, I got 3 heads. And so I think that's my point is patients don't know what they need. It's for us to let them know what they need. And I think we're very much in the early evolution, and with time the cost will come down. Thank you.
Thank you very much.
So, is this come up?
You should put them on a robot, it will be faster.
So if I put the iPod, okay, so we talked about this. Based on this equation, ladies and gentlemen, it is unjustifiable to propose global surgery should be on a revolutionary track based on robotic surgery. We are, of course, global surgeons. We need to be very careful about cost. When we cannot afford $100 to do surgery, we cannot promote a $1.5 to $2.5 million solution, which is crazy. Okay. So, what I was also going to say with that So there's a lot of risk of robotic surgery. We talked about what I am really, he's promoting, he's a Bentley surgeon. He has his Bentley, he's going to a hut to do his robot surgery. Ladies and gentlemen, would you buy a robot from him? Okay. Now, to quote a famous surgeon, Patricia Newman, keep moving. Right? Keep moving. Well, is it an evolution when you start walking and then you start sitting again? That's what we do. As surgeons, we stop, we operate, we walk. A surgeon, you know the surgeon because he's the one who's walking past it in the hospital. Now what we know, the robotic surgeon, they're the ones who are seated all day looking at something. I wonder what's in there. Okay, it's not progress. Sitting is not progress. Movement is progress. Okay, so finally, laparoscopy is the revolution. It's a radical shift from open to minimally invasive surgery. It required rethinking, retraining, instrumentation of our setup, and it has been scalable. It has a global impact on essential surgery, especially in low-income countries. Robotic surgery certainly builds on laparoscopy. It does help the people with tremors. As I said, maybe you should drink less. It offers, 3D vision, but guess what? You learn how to operate on 2D vision. Let's move. It's a high-cost option with limited scalability. Do not believe what he says. Vote laparoscopy.
I'd like to one which one. So I'll go first for who's favoring robotic. Show of hands. 1, 2, 3, 4, 5, 6. 6 people? 7, 8.
I'm also voting for that.
9. Who's voting for laparoscopy?
Yeah.
Oh my God.
So the CMO wants
I'd like to get one comment from robotic, from the audience, one from laparoscopy. I know my mentor, Dr. Joy Children, he's a pro laparoscopy.
My talk on Saturday, I hope some of you will still be here, is basically to show how robotic, the problem with the robotic goes way beyond the cost. It's a fundamental problem that is making an inflection in general surgery, surgery, not only in the United States but the world. It's a step backward actually. It's detrimental, it's harmful, because as a surgeon sitting on his console, and I'll go that in detail with all the data that you can ask for. I'm not mentioning the cost. When the surgeon is sitting on the console, what is a trainee in surgery doing in the room? For 10 years, you've been trainees sitting in the room doing nothing while the surgeon is using the robot. That trainee cannot do an operation and graduate. So we'll go over this. Hopefully I'll be able to be more convincing myself. Thank you.
I'd like Dr. Burton to speak for Robert. He's a robotic bariatric surgeon from Richmond, University. And after this, we'll have a short break and we'll have an interesting workshop from draft to publication. So there's a snacks outside. You guys can grab a snack, come here, and we'll continue with the next session. Okay. Dr. Burton for the robotic.
Thank you, Dr. Deere, for your response. But, as you all of us know, we were training the older surgeons with their pants up to their chest, staying bent over for years, and that was a great sign of an experienced surgeon. Laparoscopic surgeons who can't get off the floor when they fall and they're bent down to do something, you can't get back up, you're stiff as a board. And robotic surgeons who sit comfortably on console and can do a long surgery and still get up and function. That sort of stuff we don't talk about is ergonomics for the surgeon. We talk about patient care, patient quality, and how we don't talk about the surgeon role. And the surgeon who does robotic surgery can function as a human being after surgery. So that's one aspect of it. The other aspect of it, the visualization, the ability to see detail in the tissues is far superior to open surgery. As sometimes laparoscopy, I had a case the other day, a 77-year-old female with lab band surgery 12 years ago, who came with a perforation, and she had acute abdomen, hyperemia, injection of the organs, free fluid in the abdomen, and my resident said, let's open. And she's 77 years old. She came in with sepsis, metabolic encephalopathy. To open this patient would cause, as you know, long ICU stay, who knows what kind of outcomes. But we persisted with minimally invasive, and then we actually docked the robot, and we fixed the hole in her stomach after removing her band. And today, she's doing great. She's feeling better. Her numbers are all improved, no open belly, and the visualization from the robot was superior. So to argue against robotics, I think is futile. It's the future, it's here, and those who don't embrace it will be left behind. Thank you.
Thank you very much for that opportunity. That I think laparoscopy won. Thank you.
I have a comment.
Okay.
No open surgery.
You guys did a great job with that patient. But now let's take that patient to Sweetwater, Texas, where one of my residents practices medicine, and there is no robot. And that robot, or that trainee that you taught how to do laparoscopy, and then you taught how to do open surgery, has their two hands and a tray of instruments. How are we training our graduates? All of this wonderful stuff that you talk about is all predicated on the understanding you know how to do it open already. If you get into trouble, you can open. Now, I want both of you guys to look me in the eyes as surgical educators and tell me that if one of your trainees got into the common bile duct, that they would be comfortable doing a left costal or a right costal incision, doing a common bile duct exploration with a base dilator, and putting a Wayland Moss drainage tube in. Anybody? Anybody?
I would send it to that.
Yeah. So the technology is great. I'm just asking you as a surgical educator, those of you out there, to understand where we're going with our trainees. And not everybody has a robot, and people have scopes and whatnot. But the default answer to a problem is put a drain in and transfer them to a tertiary care center seems a bit hollow. But I'll defer to Dr. Newman